my pleasure to introduce Dr. Drice. Dr. Drice obtained her medical degree from Howard University School of Medicine in Washington, D.C. She then went on to do her internal medicine residency and pulmonary medicine fellowships at the University of Medicine and Dentistry of New Jersey. She currently holds an appointment to the Division of Geriatric and Palliative Care Medicine here at the University of Miami, Miller School of Medicine, and she has multiple presentations and publications on the topic of transitional care, including that of a novel risk assessment tool for unplanned hospital admissions. And with that, it's my pleasure to introduce Dr. Drice.
Thank you, Dr. Jacobs. Good afternoon, everyone. I certainly hope you're all safe and well. And today, the topic of interest, let's see, just so I may. The topic of interest is about evaluating and treating COVID-19 patients on site at the nursing home, the post-acute and long-term care facility. I would like to share with you our experience in light of what's happening around the world. So at the end of this talk, I hope that we can identify some common challenges we all face in the post-acute long-term care setting, particularly in face of an outbreak. Also, I hope to highlight some key elements of the COVID-19 preparedness planning in the nursing homes. And finally, I hope to present to you a new model of care for the management and treatment of COVID-19 on site at the nursing home. So a brief outline of my presentation. We'll go through a background, a quick slide. Then I'll take you in time some key dates. Then I will present a case summary of the first outbreak in the United States in a nursing home. We'll briefly speak about the COVID-19 preparedness planning in the nursing home, and then we'll go to the model. Some background. As we know, nursing homes are congregate and living facilities. Their healthcare personnel often move from one facility to the other, making the spread of an infectious disease quite easy. The residents are older, they have multiple underlying comorbid illnesses, and often they present with symptoms which are not typical. And therefore, consequently, they are probably at the highest risk for poor outcome in the setting of an outbreak. The following is a table borrowed from an early report from the CDC Morbidity and Mortality Weekly Report, March 27th. And it's looking at hospitalization, ICU admission, and case fatality percentage in age groups. And what we're able to recognize is that the older the patient population, the poorer the outcome in general. If you look at the bottom half of the table, you'll see that patients age 65 and older do have a hospitalization rate that is higher than the rest of the patient population. The same for the case fatality rate, as high as 27% at times in patients who are more than 85 years of age. So this brings us to a timeline. I'm going to take you back in time and bring you to the present moment. So December 31st of 2019, China reported a cluster of pneumonia in Wuhan province. January 20th, 2020, the first COVID-19 case was identified in Snohomish County, Washington State. And this is from a patient who had traveled to Wuhan. February 11th, the World Health Organization named the disease from this novel virus, COVID-19. February 26th, The CDC reports the first community spread in California, and this is important because this is the first time we have a patient who contracted COVID-19 without having traveled or without knowing someone with the disease. February 28, the first COVID-19 in a post-acute care facility in King County, Washington State. March 11th, a pandemic is declared by the WHO. Are strictly prohibited in nursing homes in Florida. I will start with this case summary, and it is also borrowed from the Morbidity Mortality Weekly Report, March 27. But it illustrates to some extent what happens and will help me make the case with what follows. A 73-year-old female patient with a past medical history significant for diabetes, hypertension, coronary artery disease, chronic kidney disease, obesity, and chronic heart failure developed cough, fever, and shortness of breath with hypoxia. The patient had no history of recent traveling or known contact with someone with COVID-19. She resided in home along with 130 other residents who were cared for by about 170 healthcare personnel. In mid-February, a cluster of respiratory illnesses were noted in the nursing home. Rapid influenza test into the course of her illness. The patient was transferred to the hospital due to worsening hypoxia. She was intubated, placed on a ventilator. CAT scan of the chest showed bilateral infiltrates. Respiratory viral panel was negative. BAL fluid culture was negative. 4 days post-hospitalization, COVID-19 test was positive. 3 days later, the patient expired. So this is case summary of a patient at Facility A, King County in Washington State. The CDC immediately sent for an investigation. And the following are factors which probably contributed to the outbreak in that facility. 1, there was ineffective implementation of sick leave policies for the staff. The facility was sharing healthcare personnel with other neighboring facilities, probably enhancing the spread. There was limited understanding of standard contact and droplet precautions. There was inadequate supply of personal protective equipment, and there was a delayed recognition of cases due to a low index of suspicion and limited testing availability. So the following are the results from the investigation at that facility by CDC. Again, taken from the MMWR, March 27. Out of 167 patients with symptoms who were tested, 101 were positive for COVID-19. The hospitalization rate was 54.5%. The case fatality, 33.7%, quite high. So in retrospect, the following are some lessons learned. This is what we learned from that experience. We needed to identify potential cases early. We needed to keep a high index of suspicion. And in order to prevent the spread of COVID-19, we needed to do the following few interventions. We needed to implement and strictly implement sick leave policies for the healthcare personnel that was flexible and non-punitive, that if they were to fall ill, they should stay home. We needed to source control to have both healthcare personnel and patients wear masks. We needed to cohort patients affected by COVID-19, and this among other interventions. We also needed to adhere to a strict infection prevention control policy. And more importantly, we needed to have a plan early on. So as we're preparing for this plan, let me share with you what is the emergency management planning in a nursing home. And as we face that pandemic and a definite outbreak in Washington state, we created at our facility the COVID-19 preparedness planning. And it included the following key elements: a committee that was integrative and cohesive, that included everyone, all services, from the facility administration to the medical director to supply department, environmental services. We needed a response coordinator who could stay in contact with state, regional, and local planning groups. We also needed a plan, and here is the plan we came up with. 1, it was extremely important to educate both patients and residents and healthcare personnel, and for that matter, family. It was very important to keep the communication line open. It was also highly important to manage the healthcare personnel. And as we already mentioned, not only we were implementing the actual sick leave policy, but we also initiated active screening, whereby we actively checked temperature and daily did a questionnaire just to keep patients with potential COVID-19 infection outside of the nursing home. We also assess and optimize our protective personal equipment. And more importantly, we knew that we needed to find as many testing as possible. We also restricted visitation, and this was by an order from the governor. But we needed to keep the communication between residents and family members, so we chose to do video conversations as an alternative method of visitation. It was important to enforce the infection control policies. We needed to repurpose space in the facility, and we created the COVID-19 units. A dedicated staff to those units was put together. And more importantly, we needed to evaluate and manage residents with symptoms and promptly keeping a high index of suspicion for the disease. So, armed with this, we came up with a model of care. And I remember vividly putting it together with some colleagues and other parties at the facility, and we will call this facility Facility M in Miami-Dade County here in Florida. So this model of care included the following some key elements. 1, we needed a robust infection prevention and control. 2, we needed, as we said, some COVID-19 units with dedicated staff. We needed to adopt an interdisciplinary team approach, which included a medical group, mental health team, palliative care, pharmacy, physical, occupational, and recreational therapy, nutrition, and dietary. And finally, we needed to put together management and treatment protocol. And last but not least, we needed a contingency plan in case we could no longer care for those patients on campus. So let's go through the infection prevention control. A coordinator worked very closely with an infectious disease specialist, guided by some policies from the CDC. The coordinator, again, educated our residents, the family members, and healthcare personnel very carefully. And this from the very onset, even before the first outbreak in Washington state. And finally, that coordinator implemented infectious surveillance and prevention program on campus. They were very active from the very beginning, as soon as we knew that there was the potential for an outbreak. Then we knew that we needed to repurpose space because we needed to cohort all patients who were either suspected COVID-19 cases or confirmed cases. And with the engineering department, we centralized those units in one building, just so we can avoid too much movement of COVID-19 cases on campus. We also created cold, warm, and hot zone, and this in order to keep the personnel safe. The personnel was educated consequently. And we installed multiple air filtration systems in those units, although we did not create negative pressure room, but this allowed a certain exchange and renewal of air in that area. So these prepared for the surge. The actual COVID-19 units, bed capacity 28, and at time full, needing an overflow unit, which we called the decompression COVID-19 unit, bed capacity 7. This is now the actual medical team, and we'll go through their role and responsibilities as well. So the Rule Out COVID-19 unit team included an actual unit ARNP who worked closely with the physician of record and the floor nurse. The unit ARNP made daily rounds on those patients and reported to the attending, who rounded twice a week or as needed. The actual COVID-19 unit team included a physician, a nurse practitioner, a palliative care nurse, a floor head nurse, and made daily rounds or more if needed. The decompression unit was staffed by, again, a unit ARNP, a physician of record, a floor nurse. The nurse practitioner made daily rounds, reported to the attending, who rounded twice a week or as needed. And allow me to say that we also had coverage 24 hours, 7 days a week. A nurse practitioner was present on campus at all times, 24 hours a day. And this is the triage protocol, which was carefully crafted and particularly by Dr. Marcio Suarez. And I will take you, I know this is a busy slide, but this is what helped us really do our best for our patient on campus. So with this slide, we see, I'll take it from the very center. if we had a patient suspected to have COVID-19 or an actual confirmed COVID-19 case, the first question asked, is the primary care physician doing a goals of care discussion with the caregiver? If no, a consult was immediately placed to the palliative care team, it being on campus or at the University of Miami. If the primary care physician wanted to do goals of care, and usually that was the case, then we move to the second step and making sure that the goals of care were addressed with the caregiver in light of some advanced directives, that a code status was elicited and placed in the chat. If the patient was found to be DNR, do not resuscitate, do not intubate according to their wishes, then that discussion was taken a step further with the person acting on behalf of the patient or with the patient, meaning the proxy surrogate or the patient if the patient had capacity to make decision. And we carefully assess whether or not this patient were to stay at the nursing home, if he were to decompensate or go out to a tertiary care center. And this was well understood between the caregiver and the medical team. And this was recorded in the record. Then we assess the risk factors, namely the age and the multiple comorbid illnesses. If the patient had less than 2 risk factors other than age and was asymptomatic, the patient was isolated in the COVID-19 unit if positive and monitored at the nursing home. If the patient was a rule-out COVID-19, he or she went to the rule-out COVID-19 unit. If the patient had less than 2 risk factors and mild symptoms, again, they were isolated and monitored on campus, on site at the nursing home. If the patient had severe symptoms, and namely chest pain, shortness of breath, severe hypoxia with O2 saturation less than 90% despite O2 supplement, and guided by the patient's wishes, namely whether or not the patient chose to be transferred or stay on campus. If the patient chose to be transferred, they were then taken to a tertiary care center, but then we were using all community partners around us. Now, for patients with more or 2 risk factors other than age, asymptomatic, they stayed on campus. If they had mild symptoms, we kept them on campus, but they were monitored more closely, meaning that their vital signs and saturation happened every 2 hours, and they had a frequent check in terms of their symptoms by the medical personnel, either the nurse practitioner or the assigned nurse. And at that moment, a discussion also was entertained with the caregiver in preparation for what the course of the disease might be. If the patient had severe symptoms, saturation less than 90%, shortness of breath, chest pain, altered mental status, they were transferred to the tertiary care center, again using all community partners, if this was in keeping with their wishes. And at time, if the patient was not doing well despite our intervention and chose not to go to a tertiary care center, we immediately activated a hospice evaluation. But this is something we had already decided upon at the very onset of the admission. So the following is our management and treatment protocol, some key element of that protocol. The patients were monitored every 4 hours with set of vitals, particularly including their saturation. They had an EKG on admission, and if they were to be on hydroxychloroquine daily, they had chest X-ray on admission and the following set of laboratory tests: CBC and differential, CMP, ferritin, C-reactive protein, and SET-rate. An advanced care planning was done at the very beginning of the admission. Goals of care were clearly discussed and delineated. The code status was elicited and placed in the chart. Also, a discussion was led with the patient or the caregiver regarding hospitalizing versus not hospitalizing in a tertiary care center if needed. We used the following treatment: O2 supplement and support, IV fluid, because often our patient presented with dehydration because of reduced overall intake, antipyretic, analgesics, bronchodilator treatment, and this was a challenge, as you can imagine. We could not use as much as we needed nebulized treatment because of lack of negative pressure rooms. And yet at times, our patients could not coordinate the minute dose inhaler, so we had to become creative. So we use aero chambers with masks that are often used for infants to deliver the bronchodilator treatment, and with success. The dietary and nutritionist team were very important as they provided supplement, because most of our patients had stopped eating. We made sure patients had DVT prophylaxis because they had become more and more bedbound with more functional decline. OT and PT, speech therapy, were very involved and continue to be. And more importantly, we introduced the concept of de-prescribing. For many reasons, we needed to minimize the amount of medications our patients were taking, allowing them to have only the essential medication. But also, we needed to minimize contact between our staffs and our patient as much as permitted. And so we removed all medication that were non-essential, and we grouped medication in such a way that they could be administered as less frequently as possible and permitted. And this made a huge difference. Other treatment modalities, particularly in patients who presented with infiltrates on X-rays, we use hydroxychloroquine and azithromycin in 2 of our confirmed COVID-19 patients with pneumonic process on X-rays. One patient now is doing very well, and the other patient who had metastatic renal cell CA2 bone was very ill with multiple other comorbid illnesses, expired the next day. We also used IV antibiotics if needed. The disposition of our COVID-19 patient is test-based. We use a test-based strategy and the COVID-19 PCR tests, meaning that the patient needs to have 2 negative COVID-19 tests consecutive and with a 24-hour interval, 24-hour or more interval. We also had a contingency plan because we knew that we did not have all the capacity needed to care for patients who were severely ill and who were decompensating. So we partnered and collaborated with surrounding tertiary care centers, and they understood that we would do everything possible, guided by the patient's wishes, to care for our patients on campus. But if we were to reach the point where we were not able to provide care, that we would transfer those patients to neighboring hospitals. And this was understood. And of course, we worked very closely with the hospice team, who was very much a presence particularly in the COVID-19 unit, but in all other COVID-19 floors where they rounded regularly. So this is a preliminary tabulation of the data from Facility M in Miami-Dade County, as I'm going to call it, our facility. And please allow me to say that the data is still being analyzed and sorted. But this is what we have. In red are results from Facility A in King County and Snohomish County in Washington State, but by no means am I trying to compare or draw definitive conclusions, because I think that so much more is needed in terms of data analysis to draw some conclusive, statistically significant recommendations. So we tested 377 residents. This is a total amount of residents on campus. And out of that group, 56 had positive COVID-19 tests. 10 of them expired, making our case fatality rate at 17.9%. And 10 of those residents needed transfer to a tertiary care center, making our hospitalization rate in tertiary care facilities 17.9%. And again, in red is how the Facility A numbers, how they looked. Again, I am careful not wanting to draw any conclusions yet. The following is the actual graph of our performance over time, and I will take you through this graph. It shows in yellow the actual number of residents tested on a particular date. At the bottom, we have test dates, x-axis, and in the y-axis, we have the actual count, absolute number of patients who were either tested in yellow, who turned out COVID-19 positive in blue, and who expired in red. And what we were able to appreciate as we were looking at this graph on a regular basis is that we had a few spikes on certain days of COVID-19 positive cases at the beginning. And as you can appreciate, toward the end, those spikes kind of leveled off to almost a flat line. And I am very pleased to say that over the past 10 days to 2 weeks, we have not had a positive case on campus. And finally, I just want to bring attention to the red line. We had very few deaths. And I can say that, again, over the past 10 days or so, we have not had any deaths. Actually, the great majority of our patients have totally recovered, have had their 2 COVID-19 tests negative according to the test-based strategy, and are back to the general population thriving. Granted, we are dealing with some challenges, and this is a topic for maybe another discussion, primarily the fact that they are quite deconditioned with significant functional decline, which we are actively working on and making some progress. Some of them do have suffered of the impact of lockdown and being in a COVID ward. And we have a wonderful mental health team on campus addressing this issue. And we are making progress. And again, we have other challenges, but I can say that in general, a great majority, except for 6 of our patients, are back to the general population and thriving. So in conclusion, and this is so this is a carefully drawn conclusion. As I said, this is so early on as we are analyzing our data. But I'd like to humbly propose this on-site model of care, where we are not sending our patients to tertiary care centers. We are caring for our own right there on a campus with the help of a team that is absolutely interdisciplinary and dedicated. So we'd like to propose this model of care, on-site model of care for managing and treating nursing home residents during an outbreak, happens to be the COVID-19 outbreak. And we think that it might be a viable alternative to caring for them in tertiary care centers when appropriate. Of course, as I said, this is with a lot of, we're being very careful because we have certainly certain limitations. It's a small sample number. We definitely need to test and replicate this model. So I think that I hope we don't have other instances, but this is as we do a retrospective analysis of our data, hopefully it can confirm that this model of care is indeed promising. So these are the references used, among others, but I have definite acknowledgement. I'd like to thank the Miami Jewish Health staff, in particular the COVID-19 unit nursing staff. They are an amazing bunch, and they were so willing to care for those patients. They never hesitated. I would like to thank Dr. Marcio Suarez, my division chief, who came, I remember that definitive night with the triage protocol, which I think helped and worked beautifully. And I would like to also thank Dr. Corbett for leading us at the facility and not wavering and having a steady hand when things were very difficult. And so with this, I will end my talk and we'll take questions. Thank you.
Dr. Drice, thank you very much. That was an elegant presentation, and we are all grateful for your leadership during this very difficult time in a very vulnerable population of people who we value very much. The fact that you've stayed out of the news and kept your nursing home out of the news is a major credit. However, others have not been so forthsightful, and as you know, this has become a very hot topic of discussion and a serious one as we remain still in the pandemic, and many of the nursing homes in our area, really directly in our area, are being closed down as we speak because of these problems. Is it mainly money and resources? Is it knowledge? Is it lack of, or are there other more insidious reasons why there hasn't been more broader adoption of your of the process you and Dr. Soares have proposed?
I think it's a combination of it all, but more importantly, I think that what is needed is the will to take this and work it out and make a difference. We were so ready at Facility M from the very beginning. We did not wait. Actually, when the outbreak occurred in Washington State, it was just a matter of time that it would happen. We knew it, and therefore we were prepared. We did not wait to put together a plan. We did not want to be reactive. We wanted to be proactive, and this is why we started working on this from day one. Why is it that other facilities are not doing the same? I'm not sure that they know that you need to be somewhat creative under the circumstance and proactive. And because there is really, except for an emergency management response, that is a part of their of what they have at the nursing home, how to react to some extent to an emergency situation. They don't have an actual model to follow. We were just creative, and because we knew that we needed to come up with a plan as soon as possible to meet the needs of our resident on campus. So to answer your question, sir, and I hope I am, it is a combination of all that you said, but I think that what is lacking, particularly in a lot of those homes, is the will to do it, and more importantly, the understanding that no one can be reactive in face of such, a problem. You need to be proactive.
Thank you, Jenny. That was great. Dr. Marcus, you had an excellent question. Would you like to ask that to Dr. Drice? She has to unmute herself, and I'm sure she's in the AOA. Yeah, her audio isn't working. So allow me, this is her brilliant idea, and it is a very important idea because we know that patients in facilities like the ones you work in are also deficient in vitamin D because of exposure and so forth to sun. Do you think that vitamin D levels, first of all, were they checked in any of these patients? And would you know at this point whether or not it could be protective against infection or course?
This is an excellent question. On campus, we do monitor vitamin D level quite regularly for those who believe in the benefits of vitamin D. And I know there is recent literature which unfortunately has not supported the use of vitamin D as much as we used to in the past. But under the present circumstances, no, we have not looked at vitamin D, but I think that is potentially an area that is worth investigating, because we do have the data available, just because we do check vitamin D level quite often in our resident. I'm a firm believer, because based on the literature, we still use it in terms of reducing for reduction of falls and also reduction of fractures So there's some literature to support the good use and the benefits of vitamin D in the patient population we served. But I'm going to say that I'm going to take this with me, with your permission. And that is something that as we analyze our data, we will be mindful of to see if those patients who did better indeed had been on vitamin D and whether or not it made a difference.
And correlate with the blood
Yes.
levels as well. Excellent.
Yes.
So Dr. Soares, I see you have you want to make a comment in response to the previous question. Please unmute yourself. Marcio? Okay, we'll move on to Dr. Guerra. Jorge, you have a comment or question? Well, let me, Dr. Soares' audio isn't working either. Well, we need to do better to getting our faculty audios hooked to their computers. The idea from Dr. Soares is, in case you can't read the chat, is that the model was offered to several other facilities and they were not willing to participate. Apparently there were concerns for legal issues that were brought up. Can't understand how legal would have been, what the ramifications were. Dr. Drice, do you have any insight into that?
Unfortunately, no, particularly in terms of whether or not there was any legal ramification to using the model. I'm afraid I can't answer that
Okay,
question.
fair enough. Dr. Corbett, do you want to make a comment?
Sure, can you hear me?
Yes.
Excellent, very good. Thank you, Dr. Weiss. An excellent presentation, Dr. Drice, and thank you for all your work with our folks on campus. This wouldn't have been, we wouldn't have been able to do this if it wasn't for the partnership with and that's why I wrote that comment. I really think we made a concerted effort early on at the long-term care side that we were going to do our best to care for and treat our own on campus, and then it was really in partnership with Dr. Drice, Dr. Soares. We came over and viewed the units at University of Miami and essentially modeled ours from an engineering perspective to mimic those, and then worked, basically hand in hand in the beginning of this. It was uncharted territory, but did our part in terms of, really developing the model of care in place. From a legal perspective, I don't have much of a comment other than the fact that the nursing homes, as you all are all aware, are always the target of many of litigation, and those are coming through to us now. I don't know how many, but I know people are, you see the commercials on TV. So I would assume that maybe smaller nursing homes who have less legal representation would be concerned about that. Our focus was clinical, and again, if I could just stress that key partnership between long-term care facility and acute care was key in doing what we've done.
Actually, thank you for that comment. And indeed, the Department of Medicine and UHealth in general views itself really as a pace setter in the community to be able to form these sorts of collaboratives and partnerships that really do improve the health of our community, our state, and our society in general, because it is through the ingenuity and dedication of Dr. Drice and her coworkers that we're able to make inroads into this. Dr. Guerra had a question. Do you have any idea about the incidence of the infection within the staff? You talked about the residents, but what about the staff?
If possible, I'd like to ask Dr. Corbett to answer this question. I don't have all the details on the staff, but I know that we also were very, very involved with the staff, monitoring them, being supportive, and we did well, but I don't have actual numbers, and I don't know if Dr. Corbett does have those numbers.
Not to put you on the spot, Dr. Corbett, but do you have a response?
Yes, yeah, I do. So our numbers, I was screening over to look at our smart sheet that's capturing that, and it looks like our numbers of positive employees were at 40. I'm sorry, 42, with 40 fully recovered, and no, knock on wood, no fatalities.
Good. Well, I want to once again thank you, Dr. Drice, for an excellent grand rounds and everyone's participation. And everyone be safe, and we'll look forward to seeing you in the future.
Thank you. Thank you all.
And we'll leave this up for a minute for our residents to take attendance.